Obesity Task Force of the European Association for the Study of Obesity. And this is our education and training course on obesity management. The previous one was in Serbia, in Zlatibor, so this one in Cluj, and I myself and the team are very happy to be here. I liked your town a lot. So, but before beginning, I have an announcement, which is that Natalie Arpur Lambert will not be here with us because of illness, so I apologize on her behalf. So I go directly to the course start. And our first speaker would be Professor Wojtek Heiner from Czech Republic, and he's going to be talking about the obesity paradox. And then the second speaker would be Martin Fried, Professor Martin Fried from Czech Republic. As you know, he's a bariatric surgeon, a very fine surgeon. So he will be talking to you about when to refer your patient to the surgeon. And after that, instead of Natalie, Dragan Misic, Professor Dragan Misic from Serbia, Belgrade, will be talking. He will be talking on the medical issues after bariatric surgery. So, Professor Heiner.
Good morning. First of all, I would like to thank Professor Yumuk and Professor Roman for inviting me to this meeting. It's a great pleasure for me to be here with you, and I'm really happy that there are so many here in the morning on Saturday. I'm going to talk about a little bit controversial topic, about obesity paradox, which is also called reverse epidemiology. You all know that it was generally accepted that obesity is a protective factor concerning osteoporosis. But otherwise, obesity at males, visceral abdominal form, has been recognized as a major risk factor for the development of type 2 diabetes, cardiovascular diseases, obstructive sleep apnea, and certain cancers. And it's generally accepted that both general and abdominal adiposity are associated with increased morbidity, not only morbidity, but also mortality. However, during the past decade, several very, very sophisticated studies demonstrated that overweight and obese patients with several diseases, perhaps some health circumferences, exhibit better outcomes, not only concerning the disease, but also concerning the procedure, therapeutic procedure. It means outcomes that concerning cardiovascular mortality and overall mortality, and when compared to their normal weight counterparts. So when I talk about this controversial topic, I described it as obesity paradox, and sometimes is described as reverse epidemiology. There was a paper published in American Journal of American College of Cardiology in 2002 who started a series of studies confirming this phenomenon. So look at this. Obesity paradox, this protective effect of obesity, was demonstrated in many different patients. In patients with cardiovascular diseases, and at first there are coronary artery disease patients who underwent percutaneous coronary intervention. There are plenty of studies, especially from this cohort of patients. Then hypertension, even acute myocardial infarction, and especially I think the largest cohort is formed from the patients who suffer from acute or chronic heart failure. Peripheral artery disease. It was well known in the past that obesity is not perfect. I remember in our medical department there was a special angiological unit, and even in the 60s they experienced vertigonosis in patients with peripheral artery disease in patients with obesity. Even stroke, thromboembolism, and postoperative complications after cardiac surgery. But in fact, there are many data showing that postoperative complications are more frequent in obesity. But you see, nothing in medicine is black and white. And also complications after catheter ablation for atrial fibrillation. There was a study published just last year from the Institute of Experimental Medicine in Prague. And surprisingly, also type 2 diabetes and cardiovascular comorbidity. There are many papers concerning positive effect of obesity in chronic obstructive pulmonary disease. And another cohort of patients was constituted in patients with chronic kidney disease and those patients on hemodialysis. And some critical illnesses, the data provided from different intensive care units. So let's look at the paper published about 11 years ago and look at the overall mortality in these patients who underwent percutaneous coronary intervention. And you can see here that in rather young patients, at the age less than 50 years, there is no significant difference. But in the other, you can see some kind of protective effect. Mortality is almost half of that, or 1/3 of that, in comparison with non-white persons. This was not small cohort. You can see almost 10,000 patients. So this phenomenon was demonstrated mainly in the elderly. We will talk about it later on. This is the same study of Gruber showing different BMI categories. And you can see those underweight are the most risky with regard to the mortality after this procedure. And surprisingly, really, those with very high BMI have better prognosis. We will discuss the reasons. And now, this is meta-analysis which included 40 studies. And look at the number of patients. 250,000 patients, and mean follow-up almost 4 years. And look at the better outcomes for the total
and total and cardiovascular mortality. If you look at those who were overweight or who demonstrated obesity of the first grade, it means BMI 30 to 35, these black columns, you can see some protective effect in this huge cohort. Last year, it was very, very interesting paper, which showed that 1 year mortality after acute myocardial infarction decreased with body weight categories. Look at it. About mortality rate of weight, about 9% in normal weight, and in morbidly obese, 4.6. Oh, surprising, really. I told you before that many papers were published on appearance of obesity paradox in patients with heart failure. Because there are now about 20 papers published on this topic. So it's really paying attention. And most of them show that there was some association with lean body mass in obese patients. This protective effect of lean body mass. However, the last paper published just in July this year from the cardiological clinic in Prague, they have shown association of this preventive effect of obesity with total fat mass, not lean body mass. That's really surprising. Look at this, another meta-analysis. Better outcomes, showing better outcomes for total and cardiovascular mortality in overweight and obese patients with heart failure. And you can see again, overweight patients and obese patients demonstrated better outcomes. On the other hand, obesity paradox was not demonstrated in patients with chronic heart failure and diabetes. You can see these patients without diabetes. There was a protective risk ratio is about 0.8, but if you have chronic heart failure and diabetes, there is no protective effect of increased BMI. I mentioned it before. We would like to know the causes of this phenomenon, this unexpected phenomenon. And look at this. Obesity paradox was demonstrated mostly in studies which were conducted in elderly subjects. There are some studies with PCI, mean or median age, about 60 years. Coronary artery bypass graft, 63 years. Peripheral artery disease, 66 years. Hypertension, 66 years. Heart failure, 72, 64. Complications after catheter ablation, 60 years. Stroke, 70 years. Type 2 diabetes and cardiovascular disease, 62 years. So most of these findings were in elderly patients. And what it means, about the role of age in manifestation of obesity paradox. Obese patients with this risky abdominal visceral obesity die earlier, and thus among elderly obese, those with less risky lower body obesity survive. So that's one explanation. And that's another explanation. Visceral fat accumulation increases in the young ages, but in the elderly, the rate of accumulation of visceral fat is decreasing. I will show it in the next slide how it is. Increase in peripheral fat stores in low body obesity may protect against atherosclerosis. And why? There is a high lipoprotein decrease activity and low rates of basal and stimulated lipases. It means there is not such a high release of free fatty acids, which do play a role in manifestation of metabolic syndrome. Perhaps that it would be interesting to know something more on the prevalence of metabolically healthy obesity in the other. Another factor which should be taken into account is better nutritional status in obese patients and large muscle mass, and sometimes higher cardiovascular fitness in obese patients versus in those with a low BMI. It has been shown that mid-arm muscle mass and muscle strength are really very, very important protective factors. And on the other hand, sarcopenia, muscle wasting, in lower BMI categories is associated with insulin resistance. And another factor why this phenomenon is demonstrated in the other area is that many elderly patients exhibit late onset obesity, and due to its short duration, health risks and comorbidities have not been able to manifest in full. Look at this, and accumulation of visceral adipose tissue is greatest in young adulthood and decreases with age. So this is clear. You can see how is it 5-year change in visceral adipose tissue. It's the highest in the young age. But look at this, in patients over 60 years old, there is a decrease in visceral fat mass. So perhaps it will be another factor which could contribute to better prognosis of old or some cardiovascular mortality and morbidity in old patients. In contrast to a larger waist circumference, larger hip circumference, and larger thigh circumference, which correspond to lower body obesity, are associated with lower risk of type 2 diabetes. You can see here larger hip circumference is decreasing the risk in both men and women, and as well as larger thigh circumference decreases the risk of diabetes in both men and women. And there was another paper showing that peripheral adiposity exhibit an independent and atherogenic effect in elderly women. However, there are many factors which affect morbidity, mortality, and especially cardiovascular morbidity and mortality. And one very important factor is cardiovascular fitness. And you can see that total mortality risk was lower both for obese and non-obese patients who were fit. There was no difference between obese and non-obese patients. So, I try to persuade you that this phenomenon is due partly to the age of the patients and is manifested only in the elderly. And let's talk about other potential causes of this obesity paradox. One of this is a lack of discriminatory power of body mass index to differentiate between the muscle mass, lean body mass, and fat adipose tissue. Thus, lean body mass and not fat mass is protected. But it's a question, because one of the studies, as I told you, published just this year, showed that was a protective effect on heart failure. Especially, this protective effect was especially associated with the fat mass and not with the lean body mass. So in medicine, many aspects are controversial. Another factor is that those very thin patients manifest quite severe underlying diseases. That could be another cause. And concerning those studies conducted in percutaneous, where percutaneous coronary intervention was conducted, and what could be the protective effect of obesity? It could be due partly to excessive anticoagulation in lean persons. That's another explanation. Worse prognosis in lean patients. And there was another suggestion that obese patients who are usually polymorphic have more optimal treatment than those with a normal BMI. But that's experience of this group. In our experience, most of obese patients are not appropriately treated for all the diseases, complicated obesity. Another factor which could play a role is a greater mobilization of anterior progenitor cells in obesity. And there are many other humoral factors. Surprisingly, lower thromboxane B2 levels were described in morbidly obese subjects. And it's explained by the resistance to the pro-aggregatory action of leptin. Another explanation is ghrelin resistance in patients with low BMI, because gastric peptide hormone ghrelin increasing contractility, cardiac contractility, and there are attempts to use it to treat heart failure. And if you have a ghrelin resistance in lean patients, it could play a role. It's the same with potential growth hormone resistance in patients with low BMI. And also, decreased levels of TNF-alpha in obese patients could be another explanation. Why? There is an increased production of soluble TNF receptor by subcutaneous adipose tissue. If you have a plenty of subcutaneous adipose tissue, you have quite a lot of this receptor, and you paralyze the effect of TNF. So to conclude, obesity paradox was demonstrated in coronary artery disease, heart failure, peripheral artery disease, hypertension, stroke, thromboembolism, kidney and pulmonary diseases, type 2 diabetes, as well as in response to some therapeutic procedures. Better outcome of obese patients than non-obese patients. But this paradox was mostly observed in elderly subjects. So we should take into account protective effects of nutritional status in this obese or overweight patient. It corresponds to increased muscle mass and muscle strength, and perhaps also increased prevalence of lower body obesity versus health deteriorating effects of undernutrition in thin individuals in the elderly. We should consider that not only enlarged fat mass, but also other concomitant factors may, in many cases, in addition to obesity, or even instead of obesity, causally affect cardiometabolic health. So sometimes it's not easy to say just it's obesity. There are some factors which accompany obesity and which could improve cardiometabolic health and mortality. So in summary, discussion over the existence of obesity paradox cannot lead to underestimation of obesity. It's a crucial risk factor for the development of cardiometabolic diseases, certain cancers, and many other diseases which will be reported. If you want to know something more, you can look at this paper published just this year in Diabetes Care. But to treat or not to treat, that's a question. To be or not to be, to treat or not to treat. Look at this paper published last year. Weight loss and not weight regain, not weight gain, was associated with increased mortality and morbidity in patients with type 2 diabetes and cardiovascular comorbidity. So it's not encouraging, but we have to differentiate between intentional versus unintentional weight loss. We need to differentiate between the side effects of some drugs used for the treatment of obesity, for example, glitazones, which lead to increase of body weight, but improvement of diabetes. So be very careful with interpreting all these data. We can expect patients coming to us that are telling us, my obesity should not be treated. No, don't treat it. But really, consider that obesity is very complex disease. Very different disease. It's not disease. There are many diseases with different features in different ages, and you have to take into account different characteristics of obesity. Metabolic profile, body composition profile, and on the basis of that, to decide the procedure, how to treat obese patients. So thank you for your attention. Thank you.
great to see you. And first of all, I'd like to thank Professor Roman and Professor Leo for inviting me to be here with you. Today, I'll try to touch the topic of bariatric surgery. Some of you may have heard probably yesterday that bariatric surgery is the most effective treatment modality of obese patients, at least of those who are indicated for surgery. And today I'll walk you through, let's say, a few points which may show you and give you some hints about to whom, when and how to offer and to perform the surgery. So I'm going to touch a few points. First of all, I think so it may be useful to have a look at bariatric and metabolic surgery. Here we are talking about those two entities, and I think it should be useful really to look in more detail what does it mean really, the bariatric and metabolic surgery. So this is basically the task of my talk for today. So we are talking about bariatric and metabolic surgery. First of all, bariatric surgery started 50 plus years ago, and about even less than 10 years ago, another term occurred, which is a term of metabolic surgery. And there may have been discussion whether bariatric surgery is the same as metabolic surgery, whether metabolic surgery is a subset of bariatric surgery, or, which is my opinion, but I'm not going to go into details, it's vice versa. Surgery on obese patients was always metabolic surgery, although surgeons didn't know that. And the reason why I'm saying this is that the primary aim of bariatric surgery was, in the past, was the weight loss, okay? But the weight loss was achieved mostly and mainly by fat mass reduction. And if you consider that the fatty cell is one of the most active cells in the human body, then all the bariatric surgeons were focusing on weight loss. In fact, they were affecting the metabolic status of the patient, even they did not care by that time. So in my opinion, metabolic surgery was really the first, because all the time we as surgeons were affecting the metabolic status of the patient, although we were focusing only on the scales and the kilograms lost, and we did not care about anything else. So, the bariatric surgery, this is the slide I wanted to show you, even in year 2000, was defined as surgery for weight control in patients with obesity. And apart from the very narrow view of kilograms lost, also this definition and this view on bariatric surgery made a lot of harm, because in fact we were trapped in a sense when we were, for example, trying to negotiate with the health insurance companies about reimbursement for the treatment, for the surgical treatment, and most of the representatives of the health insurance companies said, oh, what are you asking for? You're just weight loss surgeons, you're lifestyle surgeons, you're making just people thin, nothing else. So I think so that this perception of just making or performing surgery because we want the patients to lose some weight was very misleading. But anyway, still, bariatric surgery is here, and in some patients probably we're only aiming for some weight loss without any other possibilities. But in most of the patients today, we are looking at how we can affect the metabolic status of the patient. So if we stay with the weight loss and with the
Sorry, there's should be something. Okay, anyway. So if we stay with the bariatric surgery only, then it's pretty clearly defined to whom. First of all, there is some age limitations. Now in the new guidelines, we go a little bit beyond that, and what is said is that, first of all, in elderly patients, more than 60 years of age, we should consider the actual status, biological status of the patient instead of his age, which is written in his documents. So basically, we should consider how the patient looks like biologically rather than just taking into account his age. That's one thing. With the adolescents, on the other hand, it's a very, very hot topic and sensitive topic. And in my opinion, any surgery which is considered in the adolescent should be really considered in an interdisciplinary setup, and pediatricians and others should be involved in that because it's a very sensitive thing to operate on a young person. Anyway, in regards of BMI, there are international criteria, so whoever is with BMI over 40, he may have a surgery, or even whoever is above 35 BMI and having a comorbidity, he may be eligible for bariatric surgery. There is one thing which opens the door wider in body mass index, and the thing is that not necessarily the current BMI is the measurement for eligibility of the patient for surgery. And even if the patient has got a lower BMI at the point of surgery, he still may be considered for surgery. And the reason why is that if there was a previously documented higher BMI, and the patient intentionally lost his weight or under a guidance, medical guidance, he reached a lower BMI than 35, so surgery may be considered as a protective means for, preventing the patient from weight gain. So what I'm saying is, if a patient with BMI 33 comes and there is a document that he was BMI 40 before several years, he lost weight, so and he's asking for surgery, or he's sent by his doctor for surgery, then we are not telling and advising the patient, well, you should visit for half a year at McDonald's, gain some weight to be 35 with BMI, and then come again and we'll operate on you. So that's not the case, and in case there was a documented higher BMI, the patient lost his weight, he's successful, fine. However, we may operate on him just as a preventive thing. So, what we have in our hands? There are several procedures, and I'll just show you very briefly the schemes of the operations, but basically we have a restrictive and malabsorptive procedures. The difference between those two categories is clear. The restrictive procedures restrict the volume of stomach of the patient. That means that they restrict the patient from overeating because they don't allow the patient, and please, this is a very simple explanation, they don't allow the patient to eat that big portions. On contrary with the malabsorptive procedures, where they bypass a certain part of the digestive tract and thus creating a malabsorption. The body basically is unable to absorb that much calories because a certain part of the small intestine is bypassed. So from the restrictive procedures, there is still the so-called adjustable gastric band available. As you can see, it creates a small upper part of the stomach. That's a restrictive procedure. Then there is another one. You can argue whether it's purely restrictive or not, but I'm not going to go into these details. There is another restrictive procedure which is called sleep gastrectomy, which just removes this part of the stomach and leaves a tube made out of the stomach. Yesterday also we have heard about gastric glycation, which is, I think so, a modification of sleeve gastrectomy, which inverts the stomach in and also creates or decreases the capacity of the stomach for food. And there is a so-called Roux-en-Y gastric bypass, again creating a small upper pouch of the stomach, that's making a restriction, and it has also a very, let's say, mild component of malabsorption, because you bypass just a small part, short part of the bowel. Then there is a malabsorptive procedures. The I think so mostly known is so-called BPD or Scopinaro's procedure, and this is the most powerful procedure in regards of weight loss in obese patients. Paradoxically, I'm using the word paradox, paradoxically it does not create any huge weight loss in the, let's say, mildly obese or non-obese patients. However, still it's very powerful procedure in treating type 2 diabetes. On the other hand, I must say that this procedure, of course, because it's a very complex procedure, is the procedure which may be associated with most of the complications you can imagine. So, when we are wrapping the bariatric part, so the only unsolved questions now are the questions about performing the surgery on adolescents and also in elderly. Otherwise, from the weight loss point of view, there is not too much questions about it. So that's bariatric surgery. So now I would like to turn your attention to the metabolic part, which I said in the beginning may be basically the part, and bariatric surgery could be the subset of it. And there is also a pretty long history of metabolic surgery, and first in the late 70s, Scopinaro noticed that there are some comorbidities associated with obesity, clearly related to obesity, but there are some comorbidities that may not be that closely linked to obesity only. And one of his observations published in 1986 was that incidence of hyperglycemia seems to be less closely related to obesity than other diseases like sleep apnea and others. In the end of the 70s, Buchwald and Marco published a book which was called Metabolic Surgery, and I'll show you in a second their definition of metabolic surgery by that time, which is very interesting because it's a long time ago when already surgeons were starting to think about metabolic surgery, at least about the term of metabolic surgery. And then there's another big name in metabolic surgery, which is Walter Torres from the US, and he is really a pioneer in this field, and he published a lot of provocative papers on metabolic surgery, and one of them is an article from 2003 when he says, so you think we are bariatric surgeons? Think again, because he's just saying that basically we can treat with operating on human digestive tract. We can treat a lot of diseases, other diseases than diseases that are clearly linked to GI tract. So the definition of metabolic surgery from 1978 is that it's an operative manipulation with a normal organ, means a normal organ, GI tract or stomach, in order to achieve a biological response or result for potential gain, health gain. So this is the definition, and I think so it's still valid because we are manipulating with a lot of things that are healthy organs. We are operating on the stomach, on a perfectly healthy organ, on type 2 diabetic patients, and it works. So probably all of you know about the effect of metabolic surgery, and there are several studies, very robust evidence-based studies showing that really surgical approach has got a huge positive effect on different comorbidities, as you can see on this slide. The same applies if you don't like the US data. So there is data from SOS study, and what you can see is that the diabetes incidence over 2 and even over 10 years is much lower in the surgery group. Those are the red bars in comparison with the control group of patients who were obese and who were followed up in the SOS study. And the same thing, the remission of type 2 diabetes, even long term, is still, after 10 years, is 3 times higher than in the control group. So, metabolic surgery focuses on disorders per se, and the weight loss is only a secondary effect which may or may not be present. So this is a total shift, if you remember from what I started with, it's a total shift to a different perception of surgical intervention in obese patients. By the way, what do you think, why when we perform, let's say, biliopathic diversion, the most complex procedure, why the weight loss in non-obese patients or just mildly obese with BMI around 30 is not, you practically don't see any weight loss or just a few kilograms. It's interesting, isn't it, when you perform a robust, very powerful procedure on patients, they don't lose too much weight, but their diabetes improves. So, one of the potential and possible explanations is that the procedure itself restricts to certain level the calorie intake, okay? From 100 to 50, just an example. So, however, when the patient is not obese, he may have his own intake 45, because he's not obese. So he's already, before the operation, he's only consuming 45. So even if you perform an operation which restricts you on 50, the non-obese patient is still below that threshold. So the operation does not affect his weight at all. But what does it affect is his metabolic status, because that's a different means of action. So again, we can see that metabolic surgery is not linked directly with weight loss, and basically metabolic surgery acts independently of weight loss. So I'm just mentioning one of the papers I already turned your attention on, and that's Walter Corey's with this paper in '95, when he said, okay, operation proves to be the most effective therapy of type 2 diabetes. Another provocative title of the paper, Type 2 Diabetes and Operable Intestinal Disease by Francesco Rubino, one of the European pioneers of metabolic surgery. So let's go very briefly through the hypothesis why metabolic surgery acts independently on weight loss. You've heard, some of it you have heard already yesterday. There is a lower intestinal and higher intestinal hypothesis, and basically everything is based on the assumption that we make the GI tract mad. We just, divert the food to a different parts of the digestive tract which was not designed to get that kind of food. We omit a part of the digestive tract from passage of the food. Again, we just, make disturbances, and there's a cascade of answers to what we do to those patients and to the GI tract. And fortunately, this cascade positively affects the metabolic status and type 2 diabetes. So I'm just clicking on the things that might be interesting for you to read. There is one more thing in BPD, in pancreatic diversion, we divert also the bile, and we concentrate the bile so there is a higher and quicker turnover in the bile, and so that may also positively affect the whole metabolic status of the patient. So just to give you a picture of that, we leave in our operations part of the stomach. The second part is either removed or excluded. Then the food goes, which is undigested food or which is very, very lowly digested food, goes directly to an intestine, which is usually the lower part of small intestine, the ileum, enters directly that part of the bowel, and it triggers a metabolic response. Then what we do also is that we divert the bile and the pancreatic juices, which do not get into any touch with food, they do not mix with the food, for a long, long way up until, let's say, the last 50 to 100 centimeters of the terminal ileum, where they mix with the food. So all these things, and moreover, what we do also is that we also interfere with vagus nerve in the upper part of the stomach. So there are different levels where a surgery really interferes with the human gut metabolism, and fortunately we are pretty successful in treating, namely the type 2 diabetic patients. All this was kind of acknowledged by different societies, scientific societies, including the ADA, and you can see the statement of the ADA from 2010, which says, that bariatric surgery should be considered for adults with BMI over 35 and type 2 diabetes, especially if diabetes is associated or associated comorbidities are difficult to control with lifestyle and pharmacotherapy, which is a very conservative statement, but still it's a huge and big achievement, because the ADA is, from its nature, a conservative scientific society, specifically in a sense of looking at surgery. The Food and Drug Administration in the US published a statement which just states that the gastric banding is efficient treatment for patients with BMI between 30 to 35 with type 2 diabetes. Alright, there's other statements that show that there are no compelling studies yet to support the surgical intervention in patients with BMI less than 30. The EASO and EASO European guidelines from 2013 again state that type 2 diabetes may be viewed as a reversible disease, which is a very important thing. And another very important thing is that the bariatric surgery is really clearly confirmed to be beneficial in type 2 diabetes remission. I think so this is a very important statement. And another important statement is about patients with BMI between 30 to 35. In these guidelines it's said that they may be considered for bariatric surgery on an individual basis. And I think so this is a very fair statement, because even though being a surgeon, I don't say that the patient should be automatically indicated for surgery, but on an individual basis they may be considered for a surgical procedure. We did, and we published a paper on type 2 diabetic patients with BMI less than 35, where we confirmed on the meta-analysis of more than 300 patients that even in the lower BMIs, the surgical approach is effective, and basically more than 80% of patients were off type 2 diabetes medication after less than 2 years after the procedure. So, when to perform the metabolic surgery? Again, you can see the IDF statement from 2011, which clearly says when the metabolic surgery may be considered. in patients, specifically in the lower BMI patients. This is the gray zone which we have to, walk through. So it's very good that there are some statements about it from EASO, if so, or from IDF, which is a very important one, and it doesn't take into account the BMI only. There is other parameters of the diabetes which are clearly linked with the indication process of those patients. How, again, I'll click the same procedures. There is nothing new, and we don't know which procedure to perform in which patient, so I'm just clicking the same slide. So this is the unfortunate thing, we don't know yet which would be the best procedure for each and individual patient. How? This is again the statement which I have just said. There is no evidence which procedure should be used for which patient. This is an unfortunate thing, but it's very hard to make any progress specifically in this point. Okay, what are we left with? We still should find out what is the real mechanism of action of bariatric metabolic surgery, what are the best and optimal indications, ideal timing for the procedure, and the provocative question, should surgery be considered or performed in patients with BMI range above 25, type 2 diabetic? So, what we may conclude, as I showed to you, bariatric metabolic surgery acts on very, very different levels. Okay, we saw that picture starting from vagus nerve throughout the stomach and the intestine. So it's a multi-level action. And there is an independent effect on weight loss, positive effect on metabolic disorders. And clearly it's been also shown that the metabolic effect of the procedures is not directly correlated to the restriction of calories, not only weight loss, but also restriction of the calories and your absorption. There is different mechanism of action. However, we have to study that in more details because we don't know yet the exact mechanism. And no excessive weight loss is observed in non-obese patients after bariatric metabolic procedure. So basically, that's the end of my presentation, and I would be very glad if you leave this room with two messages. Just realizing that there is something like bariatric and metabolic surgery, that it can bring to the patients some benefits if they are not operated on anecdotal basis, and really if they are concentrated in centers that deal seriously with those patients. And that bariatric surgery may be a solution for a certain part of your patients. Thank you very much.
So I guess a very difficult task to speak of an excellent study. Try to speak about bariatric complications that are existing after the surgery was done, and to say at the beginning that we nowadays have a very strict and upgraded guidelines for pre-operative, perioperative, and post-operative follow-up of the patients who are operating bariatric operations. So probably the main idea of these guidelines and the society that are behind that is to try to reduce at the minimum the complications. So all these things that I'm speaking in the next lecture probably are based on the experience that were followed for every days of bariatric surgery up to now, and we need to know them, but luckily we are not witness of very many of them after the bariatric surgery was done. Officially we can divide them in metabolic, nutritional, infectious and anatomic complications, and this is one. There are many divisions how some of the authors are looking at them. You can divide them on short term that are for the first 30 to 90 days, and they mainly are connected with surgery complications, anatomic complications that are coming after the surgery, like nausea, vomiting, dehydration, fatigue, leak, sepsis, gastrointestinal bleeding, and there are long-term complications that are coming 90 days after the operation. It could be fistulas, diarrhea, dumping, hypoglycemia, failure to maintain weight loss, vitamin and mineral deficiency, etc. And one of divisions was as early complications, anastomotic or staple line ribs, postoperative hemorrhage, small bowel obstruction, late complications, gastroenterostomy, anastomotic stricture, marginal ulceration, gastric fistula, weight gain, nutrition deficiency. When my team was educated in Arctic Hospital in Norway for bariatric surgery, the surgeons who have experience, this is the point that Martin told you, that patients should be operated in the centers of excellence, who has the most experience, who has experienced surgeon. They immediately, if they found something is wrong, they started to reoperate the patient or to sew. If there is a hemorrhage, we think we should go with X-ray studies, all these things. And they say, no, we are going strictly because they know this can be find solution in surgical hands, and they start immediately to try to reoperate the patients. And there is also the paper from 2007 about gastrointestinal and nutritional complications following bariatric surgery. Again, early complications in the hand of surgeons, and there is also a paper by Professor Rudolf Weiner from Germany, who tried to see what was going on with early complications, what was the reason, and how long was the hospital stay. It's an interesting paper with which he made a summary of his own experience. You can see that among the main complications that they found in that patient was the leakage, bleeding, extraluminal and intraluminal combined, and there was a problem with the abdominal wall. And it was, you see the numbers. The numbers are very small, as I say at the beginning of my talk. And then they tried to see what is going on after this, let's say, long complications, prolonged hospital stay, and they found inflammation as a possible reason, respiratory complications, throat site hernia, small intestinal obstructions, wound infection, gastroenteritis, arrhythmia, intolerance to oral fluid, and a lot of other complications. And if you look at the left band, you can find gastric prolapse, band erosion, obstruction, port problems. Prolapse is looking like this, and in gastric bypass you can expect abdominal pain, nausea, obstruction, internal hernia, anastomotic stricture, occasions, weight gain with staple disruption, diarrhea, making the problem experiences are behind diarrhea. Very often, one of them is dumping syndrome. Second one is bacterial overgrowth in the small bowel, and the third one is bile acid diarrhea that is produced by a lot of bile acid that is found in the pouch. This is a marginal ulcer that can be found, and causes are acid gastric fistula, tension of the skin, and ischemia of the place. This is the step line obstruction of gastric fistula. Nothing is looking better than me, but I must show all these things. This is related to us, to age, okay? It's less frequent in divided thorax, and it's a reversal method, and there is anastomotic stricture also. Incidence is rather small, between 1% to 50%, depending on the experience of the surgeon. with nausea, vomiting, and attraction, defined as inability to pass very tiny endoscope, and it is trying to make dilatation. And internal hernia is also 2 to 5%, and there are intra-abdominal spaces were created during surgery, and that could be fulfilled with the nuts. There are a variety of presentations, and what the surgery is a solution for the problem. Diarrhea, I told you, is a 3 possible causes: dumping syndrome, small bowel obstruction, overgrowth with bacteria, and bile salt toxicity with water diarrhea, and it can be treated with the process of cholesterol. And Hans Kramer made an interesting disease last year, also one preview with a focus on malabsorption and dumping syndrome after as a medical complications after bariatric surgery. He divided dumping in early and late dumping. Early dumping is due to rapid pass of the food into intestine, and there is osmotic shift of the solutions in the neighborhood organs. This is very easy to explain, and the late dumping is coming 2 to 3 hours, and mainly is due to reactive hypoglycemia. And there in the beginning for late dumping, there were a couple of explanations which can explain why it is going on and what we should do with this. And in a perfect review, which is due to which explain what is going on with hypoglycemia after bariatric surgery, incidence and mechanism, there are three possible explanations why is hypoglycemia happening after bariatric surgery and why this is so-called late down. One was that there is alterations in beta cell mass. If you have obese people, you have, let's say, some kind of hypertrophy or increased number of beta cells that after the operation could progress to some stage called acidocytosis, proliferation of beta cells, and that do not react normally on glucose levels. They have, let's say, much greater reactivity, which results in hypoglycemia. The reason for that in the beginning was the reviews of John Series in Patti, which even in that early days of bariatric surgery, making after bariatric surgery, having big trouble with hypoglycemia, they performed partial pancreatectomy in order to try to reduce the beta cell mass in order to protect the people from severe hypos that happen after bariatric surgery. The second suggestion was that there is alteration in beta cell function, that they react extremely with insulin response, and the reason for that is probably the thing that Martin suggested, that a lot of gastrointestinal hormones are secreted in a rather different way. For instance, there is excessive release of GLP-1 after the bariatric surgery, and that could lead to excessive insulin response that results in hypos. And the third one is that there are so-called non-beta cell mechanisms, meaning that we have alterations in other hormones, ghrelin, PPY, oxytocin, which can also lead to some secondary dysfunction of beta cells, leading to hypos and making this late dumping. And also there are possibility to have increased incidence of gallstones. Some surgeons perform cholecystectomy during the bariatric operation as well. And also there is an aggravation of non-colic fatty liver disease. Colitis happened in 25 bariatric patients prior to cholecystectomy, and 35% of the surgeons performed concomitant cholecystectomy. And also the incidence of MASH of non-colic fatty liver disease is about 90%. And there is a possibility that bariatric surgery can potentially reverse fatty cirrhosis that exists in some of the very obese patients. However, the other possibility is that initial rapid weight loss following bariatric surgery can cause hepatic decompensation in patients with MASH. That's also the thing that we should care about. And concerning the inflammatory markers, you can find that even a year after bariatric surgery, you get some elevation of C-reactive proteins, and you have some elevation of cortisol that exists in many people. And a year after bariatric surgery, they decrease their cortisol levels. Also, you can see that there are a lot of changes in so-called cardiovascular risk markers in the profile, and this is going down this C-reactive protein a year after the operation. And if you are trying to see the etiology of post-operative nutritional deficiencies, are also very common, you can think about several things. First, there is about estimation that 15% of the patients has the deficiency before the operation. As a possible reason for that is that they have altered dietary intake, they have decreased intake after the operation, they have small pouch, they have changing food preferences. There are anatomic post-operative complications which can contribute to this etiology of nutritional deficiency. There is malabsorption of gastric nutrients, and the deficiency depends on the procedure that was done. There are different to see from presentation, and individual patient's compliance. Deficiency can happen years later, and the serum levels are not often very good marker of the deficiency. Sometimes we found something that seems common, but it's not enough for the patient. And you can see in the down part of the slide that there are a couple of very often, let's say, complications in some kind of operation, not in each of them. You have here the vertical gastric band, you have the pancreatic reversion, gastric bypass, and gastric sleeve, and you will find that in the pancreatic reversion, let's say, one more serious operation, you will find often severe malnutrition, fat malabsorption, vitamin D, blood deficiency, iron deficiency, folate deficiency, thiamine deficiency, calcium deficiency, metabolic bone disease, and cholelithiasis. But you cannot find contrary of them. It's less common in gastric bypass or in the pending operation. And this is the scheme that demonstrates this thing that I told you, that 15% of the patients before the operation already have some kind of malnutrition. And here it's listed a long list with all these deficiencies that are listed in preoperative patient. And causes of that before bariatric operation could be over-ingestion of low nutrition food with high calorie foods, low ingestion of high nutrition density, foods, high fat diets with low vitamin A, C, and folate, and type 2 diabetes, let's say, put to overfiltration could favorize some of the defects. And also we need to know the site of absorption of each separate of the nutrient in the gastrointestinal system. We have 4 different sites: stomach, duodenum, ileum, and liver, and a lot of these separate substances that are existing in each of the parts of the gastrointestinal system. And you heard from Professor Martin that there are different types of operation, and each of the operation would have each sequela on the absorption. And what we can find clinically in a patient who have nutritional deficiency after bariatric surgery, we can find edema, skin rash, hair loss, stomatitis, glossitis, altered taste, night blindness, diarrhea, and anemia. Very common things that you can find in other diseases, but you should know all this if you are followed. And probably this is the reason that in this specialized centers of treating the patients with bariatric surgery, there is let's say, a new definition of a physician, so-called bariatric physician. The physician that should know all these things. Probably he should know a lot from the surgery. He's not a surgeon, he is probably from internal medicine side. He should know gastroenterology, endocrinology, nutrition, and his definition is bariatric physician. Probably the people that are, let's say, best suited for this type of consequences of bariatric surgery. And really, the second, the further symptoms that we can find in patients after bariatric surgery could be neuropathy, abnormal gait, muscular weakness, osteomuscular pain, depression, memory problems, confusion, encephalopathy, cardiomyopathy, heart failure, and poor wound hearing. I say it's a small percentage, it's not a very common one, otherwise we would have the problems. But we should know them and we should take care about our patients. And also beside the micronutrient deficiency, there is a macronutrient deficiency which can express themselves in dehydration and protein calorie malnutrition and hypoalbuminemia and clinical presentation, edema, alopecia, slow healing. And we should monitor album, needed there twice a year, and if needed, put substitute there. And also, there is a protein calorie malnutrition that is existing after bariatric surgery, and we should make adequate food substitution, consisting on 60 to 120 grams of protein per day. And also, there are a lot of micronutrient deficiency after the surgery, and the prevalence of them, depending on the type of operation, some of them making worse, some of them making less deficiency. And if we want to prevent that, we should insist on supplementation, and it's very well written about these post-operative guidelines for patients after bariatric surgery. And supplementation must be done with non-enteric coated products in some oral solution, and we should follow up the withdrawals and routinely substitute the patients every day in subsequent years. Up to 5 years special care is taken. After that, she has so often. And there are a lot of deficiencies. We don't have time to pass all the symptoms. It's iron deficiency, calcium depletion, vitamin E deficiency, vitamin A deficiency, folic acid deficiency, vitamin B12 deficiency, thiamine, vitamin B1, and it could lead to some very bad disease, post-bariatric very bad disease. It's interesting topic. And vitamin B6 deficiency also as well, and B2 deficiency, vitamin C deficiency, zinc deficiency, selenium deficiency, and what you should follow up with your patients every 6 months. You should do a hemogram, live antigens, glucose, creatinine, electrolytes, iron, vitamin B12, folic acid, calcium, PTH, vitamin D, aluminum, theodorin, and optionally you should follow vitamin A, zinc, thiamine, and other vitamins. You should substitute maintenance of minerals, and if I told you that there are due to deficiency of thiamine found and B12 can found neurological complications, and there is also a list of vitamin deficiency that could lead each of them to separate neurological complications, mainly sensory neuropathy or myopathy. And I told you that this acute post-bariatric surgery neuropathy called bariatric very, and incidence is 3.6 after 14 months and 4.6 after 20 months. There is the reason for that is thiamine and B12 deficiency, and the treatment is very easy to substitute with nutritional support and iron and all this. You can so-called adverse bariatric surgery very. And there is also a possibility, but luckily in a small number of rare encephalopathy, and it can result in dietary deficiency, oculomotor abnormalities, cerebral dysfunction, and impaired mental status. And if you give parenteral time, you can solve the problem. Pathologically, mainly anemia with iron deficiency, B12 deficiency, and folate deficiency. And in the field of endocrine complications, you can find so-called bone disease, bypass bone disease. That's prominent, can happen with altered bone metabolism. And you have heard from Professor Obesity that you are treating that it is extreme if you can find bone deficiency to theoretically maybe to newly developed diabetes. And especially this was the review this year in obesity surgery about bariatric surgery, bone loss, obesity, and possible mechanisms that are behind that. And it's a common problem that can be found in patients. We still do not know the reason. There are potential mechanisms which explain it. One of them is that there is a change in weight loss per se. If you lose the weight, you lose the mechanical component of the signals that are going to the bones, and it could lead to the altered bone metabolism. This is one possibility. The second possibility is that you have the leptin influence on bone cell progenitors, and the third possibility is that there is a change of adiponectin which has its anti-osteogenomic effect. So probably there are a couple of possibilities that explain something is wrong, but we do not know still the explanation of what is behind that. One of the possibilities is that also there is altered vitamin D status in patients, and it could lead also to secondary hyperparadism, which can affect this altered bone cell metabolism. Concerning cardiac complications, there are two. Again, one of them is bariatric very due to the deficiency of vitamin B12 and thiamine, and the second one is Cushing syndrome. It's an interesting kind of cardiomyopathy due to selenium deficiency, and it was described in China in one province who has a low selenium in the ground. If you have low selenium, that could lead to cardiomyopathy more. And if the lack of selenium could also influence on severe form of Coxsackie virus, so combination of Coxsackie virus and dilated cardiomyopathy results in this Cushing syndrome, and you can find in some extreme cases after bariatric surgery selenium deficiency who can bring this patient to this Cushing syndrome. That would be all of my talk, but luckily it's the small numbers, and students here he can tell us the real numbers after you see show you the plus or minus experience. Every clinic has its own experience, but it is all incorporated into the guidelines. I think it's the most my suggestion is to follow the guidelines. If you follow the guidelines, you have everything inside, and if you treat the patient according to the guidelines, you reduce the number of possible complications. Thank you.
We had excellent presentations, and now we have some time for questions or comments.
I wanted to ask you, Professor Fried, you tell us the suggested body mass index. What's the upper number of body mass index? Because my surgeons do not like to operate the patients who are very good, so to say. What was your experience? The largest, whatever you operate?
So, we don't like to operate high body mass indexes as well, because it's a struggle and a challenge. However, I must say that our largest patient was, I think so, if I remember correctly, with the BMI over 70. And, well, then you have to decide. There is two options in those patients. Either you can go, if you operate on them for obesity, of course, then you can either go with the most effective and most powerful procedure immediately, which is risky for them, but if you succeed and if they succeed, they will lose weight and there is no need for another operation. The second choice is to go with the least aggressive procedure, the easiest one, associated potentially with the lowest complication rate, as a first step procedure, to let them lose some weight and then to take them for another definite procedure. So there are two possible approaches in that. They have to be assessed individually. But we have operated on a patient with, I think so, 70.
Thank you very much to all our speakers from this morning. I was very happy to find out a lot of news, and I have two short questions, if I may. One is to Professor Heimer. Indeed, this subject of paradox is a very sensitive one, especially if discussed outside of very specialized environment, and a lot of incorrect messages can be present from this subject. And I want, in fact, to ask you if we have some data regarding the difference between unintentional and intentional weight loss once this disease occurs in obesity, and this data to clarify the situation.
There are several papers showing that intentional weight loss is positive in most patients, but in some cases, I would like to ask Martin Fried about an obese patient with a high physical fitness, man, 60 years old, elevated fasting glucose, nothing else. I think in this case, I would like suggest surgery. It's necessary to differentiate, yes, because there are other factors, not only obesity defined by BMI, but fat-free mass ratio, muscle strength, physical fitness, and there are other factors which are affecting the outcome of weight manipulation. Yes? So you have to consider the patient as a whole with all the aspects. And I think that's the message. Yes? Be careful in reducing weight, especially with this high physical fit man, and especially with the other. That's it.
And the second, if I may, was for Professor Fried, but my second question. I wanted to know, I don't remember to have seen data what happens in post-bariatric surgery, of course, or metabolic surgery, in patients with central adiposity and in patients where adiposity is mainly located in the periphery part of the body, let's say.
Well, I don't remember from the top of my head the studies, but I'll tell you our experience. Of course, I love to operate on patients with peripheral obesity because it's easier, much better to operate on them. Actually, I must say that about 80% of our patients are women, and we see more peripheral obesity than central obesity. And I remember that there are some studies which show that people with peripheral obesity reduce more weight and better, and are more compliant than with the central obesity. Although I think so that the risk, of course, is a different one with the central obesity. So that's what we know. We know also that bariatric surgery is effective, but it's not that great on central obesity. That's one thing. Another thing is that I remember that there were studies that were looking at resection of omentum and other fatty areas in the body during bariatric surgery, looking whether there is different if you remove 5 kilos of visceral fat. And I think so that there was no difference in the outcomes. So therefore, there is no performed omental resection anymore. There was only just study because it showed no difference. But maybe others have some more experience and can remember some studies and data about this.
Before your question, I want to comment on the first question to Professor Weiner. And he, I think, was mentioning about the metabolically healthy obese and the role of BMI. Or further beyond that, looking into the medical position and find the compound. Am I right?
Not only metabolic health activities, yes. There could be also obese patients with some complication, as heart failure, for example, who will not respond positively to obesity research. Not only metabolic health activities. Yes?
I would like to ask a question to Professor Mincic. These nutritional deficits that we have observed, 1 from 2 or 3 patients have actually nutritional deficiency. Do you think that immediate nutritional intervention will modify these high percentages?
The nutritional intervention will modify.
Yes.
Definitely, and nutrition is part of the picture, guidelines, and these nutrition recommendations are so important in postoperative follow-up. Even in preoperative, you see 50% of deficiency even before the operation, and they can impair the operation. So the preoperative evaluation and management as well as postoperative are still important.
I have a question for Professor Mincic. What is the incidence of nesidioplastos in bariatric surgery, and how do we treat it? Through pancreatic resection or through drug therapy?
The incidence depends on the centers. I told during my lecture that the very first suggestion by John Sevis group, it was, as far as I remember, 3 to 5 patients, not percentage, small number of patients. And I discussed this problem because in my clinic we are working with GLP response before and after the operation on a mixed meal stimulus, and we have extreme secretion of GLP after the operation. So one of the possibilities for this is that GLP is responsible for that. I discussed it with Professor Now, who described all these ingredient effects, and his thing is that it's a very simple explanation that is laid nothing and nothing more behind that, and this is his theory. The second theory is developed by Professor Holz from Denmark for Copenhagen. They are insisting on GLP response. And in the beginning, even this team of John Sevis, who is working a lot of, just even in cases of pneumonia, he described a lot of patients with nesidioplastos. They performed, after bariatric surgery, they performed this pancreatectomy, or can in order to resolve the hypoglycemia. The routine way nowadays, if you have severe hypoglycemia, you cannot manage let's say, recommended by multiple frequent daily meals. You should use somatostatin almost 25 to 30 increments 3 times daily, 30 minutes before the operation, or some diazoxide even if you have severe hypoglycemia, you cannot solve somatostatin. Diazoxide can help also as well. This is the recommendation, but probably Professor Martin knows better this incidence. I think it's not very often. It's just a question of, let's say, lighthearted with hyperlipidemia. Sometimes it is. And I like this explanation of severity. Probably the residuoblastosis existed before the operation, and the operation somehow was aggravated the whole story, making that this sense to get all of this.
Any questions, comments? None?
Discussions for this second part of the course. We'll have two speakers. Unfortunately, Natalie should have talked about children, about visiting children, could not come due to personal problems. So we have two speakers and also time for discussion, practical discussion. So please prepare for this discussion and comments. The first speaker is Professor Yomuk. He will talk about lifestyle obesity management.
I assume that most of you are physicians and are taking care of these people as physicians. And you all know that lifestyle modification is the cornerstone of obesity management. And you may be asking yourselves, what is this? And going to talk about, more about lifestyle modifications. Is there anything new that you don't know? Well, in essence, there isn't anything that is new, but eating healthy food and ending physical inactivity, and also behaving yourself is just using your brains and getting help for to do that. So this is my word. I like this word very much. I borrowed this slide from Tony Bishop. Thank you a lot. So let's look into what we're going to be talking about. I'm not going to be talking about in great detail about the study. This study you know, and yesterday I spoke also about my presentation. But what this slide shows us, and what we tell us, what we tell our patients in our practices, lifestyle intervention helps a lot. So with this, with the weight loss of 3 kilograms, you have a 58% decrease in reduction in type 2 diabetes. This is very important. Now I can greatly say, in my opinion, that if you do eat healthy, if you lose weight, if you increase your physical activity with this, write a prescription for both, send the patient to the practitioner. So I would not say that you have, if you follow these rules, you can reduce the incidence of type 2 diabetes if you are pre-diabetic. And that was a European study. This is an American, the USA study, and there you have a similar, almost the same percentage of type 2 diabetes reduction, only with lifestyle intervention. And the group with metformin had a less reduction because they didn't have an intensive lifestyle. So I think the is we can't be without these two, healthy eating and physical activity. This slide I showed you yesterday also, but it's a summary of healthy eating. You see the percentages of the macronutrients here in the middle. The fat part, as you know, is, again, fat is also in the middle, but the content is important in regards to atherosclerosis and in people with or without diabetes. Fat has the highest calories, as you know, so you may be thinking about lowering the amount. So high fiber is healthy, dietary fiber, a certain amount, salt, especially for reducing hypertension, is very important. So this is the picture of healthy eating that we all know so far. In dietary interventions, when you give dietary information to your patient or the dietitian that prescribes a diet for the obese, it would be a hypocaloric diet. So there would be a negative energy balance, which is you get less than you spend. You would know when devising or suggesting a diet that the need would be varying by gender. For men, would be more people who have higher weight and activity would need more energy. And if you go with the low-calorie diets, which is usually done, you would have at least start with a 500 calorie diet and up to 1,000 or even more. There should be calorie deficit. When I went to real food, it's usually food that is very important for nutrition and our health. I don't know how much experience you have with meal replacements here in Romania. So I think we should go with the real food. Meal replacements can be used in certain cases. They are expensive under supervision. Very low calorie diets, diets that provide less than 800 calories per day, this is not recommended. And if given, should be done under supervision. After supervision of a physician. Again, complementing what I have said before, excess dietary fat is stored in adipose tissue, so that's creates obesity. When you take fat as a macronutrient in the diet, the diet-induced thermogenesis by fat is lower than the others, and fat has little effect on appetite. These are the known fats. We may, in certain cases, or most of the cases, in order to reduce the amount of calories, since fat has the highest amount of calorie per gram, which is 9 calories per gram of fat, 1 gram of fat. You would reduce fat intake and may, at the same time, increase the context of unrefined or complex carbohydrates, reduce fat and increase protein, unless contraindicated, as we talked yesterday. The part of physical activity prescribe what patients are either unable to do or are unwilling to do. And as you see here, it works in a way that creates a negative energy balance. Physical activity spares fat-free mass during weight loss, so that is something very important. Improves cardiovascular fitness, so fitness comes with regular physical activity, either programmed or leisure time physical activity. I wouldn't, in most cases, we don't recommend just physical activity to do without other restrictions. So physical activity, with all its advantages, should come along with calorie restriction in the diet. And so physical activity is also important for weight maintenance, increases the rate of weight gain. So these are very important issues, and we all sure that our patients are really following through for our prescriptions. As far as physical activity is concerned, this study showed that you can combine with a hypocaloric diet, there will still be weight loss, even if you do a program for a lifestyle physical activity, if you're involved in such a physical activity. So I think for those who can do programmed physical activity, which is exercise, could be aerobic exercise, or could be resistance. It depends on the patient's condition. But again, as you know, it's expensive. You may not have access to a fitness center or anything that you can do at home would be advisable and beneficial. These are the recommendations for physical activity that all of us do every day. About 2,000 minutes, 210 minutes per week is what we should be, what is expected from us, the least, I should say. And in most of the studies, this goes up to 175 minutes per week. And it could be greater activity levels, as you see here. At least 1 hour a day, or moderate walking, or 30 minutes of jogging would be helpful. So the dietitian prescribed the diet. Who gives the physical activity prescription here? The physician?
Usually, yes.
So there's no professional
No.
for that?
Only a few settings, especially applies to physical, well, kinesiotherapy. And this kind of institutions or this kind of settings might have a specialist in kinesiotherapy. Otherwise, no any other specialists.
Well, in my country, in Turkey, again, this area is not clear. I think there's someone who wants to say something. In Turkey, the area is not clear, so it could be sports physicians or sports teachers.
Thank you. I'm from Iran. I'm a specialist in diabetic nutrition and metabolic disease, and I also do physical medicine and rehabilitation. And we had more than one center when we had a program for obesity and diabetic patients.
So, physical therapy, rehabilitation medicine, as I understand, and physiotherapists, we have in Turkey, in some countries in Europe, they say they are dealing with this matter. So, whatever the recommendation is, if you give a prescription, like prescribing a drug, that's more helpful in the beginning. So it's like prescribing a drug, so the patient has to take it every day. And the patient posts it, puts it on the door of the refrigerator. So that's very important. The refrigerator is a very important place to put notes on in houses in Turkey. Yeah. So what I'm coming to is, I think the most important thing is to have your patients do whatever they can do, either in dieting or physical activity. You can't prescribe a diet or physical activity that the patient will never do. The patient will never do. So prescribe something that the patient can do and will do. To fortify this, I think, since this is a behavior change, you need, again, another professional. So you need time. Us, physicians and the dietitians, we have our own job, but we don't have enough time for this kind of therapy, because this needs time. We add to it as much as we can, but clinical psychologists, for example, who are trained, who are specialized in obesity management. I assume that there are psychologists here. Psychiatry, if needed, can help with medications regarding psychological issues, but the clinical psychologist, or in some countries could be nurses who are giving educational nurses. So there should be someone devoted to such a therapy. And these are really very important things, aspects of behavior modification strategies. As you can see here, to set a goal. Well, the goal has to be, there has to be a goal, and the goal has to be realistic. How much weight am I going to lose, the patient will ask. And, well, we would say it will be gradual. No, I don't want to, I want to lose faster than that. You would explain why not. Well, why you're not prescribing such a treatment. Rather, too quick, too fast weight loss is dangerous to your health, you would explain. And especially with the low-calorie diets, when there's a 500 calorie deficit, 0.5 kilograms per week. If the deficit is 1,000 calories, then you have 1 kilogram weight loss per week. So you would explain at least 2 kilograms, the most for, it will be more in the first month, and then you would say the rate will decrease until the 6th month, and you would explain why. So you have to tell these as the physician who first sees the patient. You have to set the goals, the activities, the activity goals, and you should explain why self-monitoring is very important. Because the patient has to do most of the things himself or herself. You show the way. If the patient is not involved in it, then you don't make any results. So most of the patients love to fill in diaries to make them comfortable. and they may have, you can see their eating patterns there. They can even write the activity pattern. And the time they ate something which was unhealthy. So the diary could help you. So the patient, some patients don't want to know how much they weigh. They don't go out to balance. So they should weigh themselves every day. Other aspects that should be stressed on for the physical activity to have stimulus control. Again, putting or keeping walking shoes in sight would stimulate the patient to go out and go, or do something in the house, at home. At least it will initiate physical activity. The problem-solving issue could be step by step, changing, modifying behavior, and to discuss the obstacles to adherence to exercise, diet, and medications. And then comes cognitive restructuring, again to fortify and encourage patients with intelligence, effort, power, so the patient doesn't feel weak, and so weak that the patient cannot manage all of this. So I think behavior modification therapy is very important, and I think also in my practice, in my country, is something lacking because of scarce amount of professionals dealing with this matter. I wish that I had 3 hands. One microphone, a glass of water. I have a case here. So I talked to you about 3 issues: diet, physical activity, and behavior modification. So, and then drugs coming. Professor Zygos we told me about, and you've also heard about bariatric surgery. So this is the treatment of obesity. According to the patient individualized treatment, so you pick up which patient needs what, but lifestyle intervention is always there. So let me go over this case. This is a 44-year-old woman who comes to you and tells you that she wants to lose weight because of her health problems. She wants to become healthy. Her history is notable for hypertension, snoring, daytime somnolence. When you snore in daytime somnolence reminds you of mental disease. And osteoarthritis. So these are complications, comorbidities of obesity. Her father was obese and had type 2 diabetes, so this puts her under risk of type 2 diabetes. First degree relative, let's say one relative, 30% risk. Obesity has outcome. On physical examination, 98 kilograms, BMI 32.7, waist circumference of 1.2 centimeters, and blood pressure 1 40/92 milliliters per mercury. And no stigmata for Cushing's syndrome. The fasting glucose level is 112, so this also brings in another issue. Cholesterol 205, triglyceride 224, HDL 40, and LDL 120. TSH is normal. So, what would you advise to this patient? First of all, what kind of a diet, what kind of exercise? Any volunteers? You see such patients? Some of you? Others?
Come on, that sounds so difficult.
So,
First of all, you need a microphone, or you can speak louder, it's not any problem.
well, let me go through this approach. First, then, may I ask, or if you want to comment on that,
They know, but
us.
they are shy. Yeah, yes, they are shy. Who is not shy? A boy? Hmm? Okay, so let's go over this evaluation and
All right. So, this, as we see here, you calculate the BMI, you measure waist circumference, and then comes assessment for existing conditions. And that would be mainly blood pressure, glycemia, and the liver profile. Liver function also is important for fatty liver in such cases. The disease, the disorder that I was talking about with snoring and somnolence during the daytime is sleep apnea. So these patients have high frequency of sleep apnea. And blood pressure, you measure the blood pressure and go according to the guidelines. Glycemia, as we saw here, is about 100 milligrams per deciliter, so it is impaired fasting glucose, so this makes the patient pre-diabetic. She has a diabetic father, and they have a history of macrosomia, maybe birth weight about 4 kilograms, or have a history of gestation diabetes. So you would get them from the history. Blood pressure is a physical exam. Glycemia you can do since this is a pre-diabetic and obese, high risk of type 2 diabetes, you may go for a oral glucose tolerance test with 75 grams of glucose and evaluate the second power glucose value. For the lipids, the LDL level could go upward. If you go according to the LDL level, we have one risk factor, or according to the number of risk factors, you set the target range, the upper limit for your LDL cholesterol. The risk factors for lipid management in this case would be smoking, diabetes, hypertension, gender, and family history of cardiovascular events at early age. transaminases, and if they are elevated, that's steatohepatitis patient has, or the transaminases will be normal, or the gamma GT you would evaluate also. And if you do by any chance abdominal ultrasound, you would see the fatty liver the patient has. Sleep apnea is important, so you would go with for the patient, you would send the patient to sleep laboratory. Do that here?
Yeah.
Sleep laboratory, stays there one night, and the oxygen information rate, ratio is measured. If decided on sleep apnea, the patient will get the CPAP instrument and uses it mostly at night. Well, for heart disease, you would also evaluate for imminent heart disease. Cancer risk, well, I don't think you could go for a screening this time, but you would advise the patient about obesity and risk for certain cancers. So, lifestyle considerations as we come to the management. You have diet, increased physical activity, behavior, education, and then you can add pharmacological considerations. And after that would be surgery for certain patients. These are my points. Dieting, physical activity. In the diet, we can discuss low-fat diets, low-carbohydrate diets, low glycemic index diets, and high-protein diets. I think these are reasonably discussed. There are other diets that are called charlatans. Charlatan, that's the term in English, charlatan diets that we wouldn't recommend. I brought in some evidence. There are more, but these are major studies showing that in severely obese subjects with high prevalence of diabetes, what the patient lost more weight during 6 months on a carbohydrate-restricted diet than fat-restricted diet. So, carbohydrate restriction, is it feasible? How long will the patient adhere to such a diet? This is 6 months. Or shall we bring in the glycemic index in such patients? A modest increase in protein content and a modest reduction in glycemic index led to an improvement in study completion and maintenance of weight loss. So, study completion means you extrapolate it to life, the adherence of the patient to the diet. So the life is not 6 months, mostly it's normal that. So it's very important that the diet is also very important to the adherence. You can't give such diets that the patient cannot adhere. And then another study said reduced calorie diets result in clinically meaningful weight loss regardless of which macronutrients they emphasize. So here we can discuss on high protein diets. How high? Modestly high. What is modestly high? Boom. So I think these are points to discuss prescribing your patient the diet. As I said before, the diets, like other treatment modalities, are individually tailored to the patient. Any comments on the diets?
inexperienced with any kind of diet, even the charlatan diet. It's time to discuss. And I know it's very important because everybody wants a special diet, and you know that patients when come to us ask for different diets, ask for very successful and commercial diets. So we have to deal with this desire of the patients and to apply the right approach in terms of diet, and not only. So I'm sure that you have experiences with different kind of diets. What would you prescribe? Let's say the case of this lady who has pre-diabetes, who has also dyslipidemia, who has hypertension. What would you recommend? First of all, what would be your objective in this specific case? How much weight to lose? For how long? And how long time?
Okay.
Yeah.
I will try. Okay, at the end. I'm okay now. So I think I would recommend a Mediterranean diet first. I think I missed the height of the lady. So I can start with a total calorie intake to just like a low sodium diet because of her hypertension, and a low fat diet first.
What does it mean low fat?
Under
Low fat,
under 30.
under 30.
Under
Okay.
30, yes. And increase
Under 30 might be 20 or 25.
between 25
And
and
30.
because I will increase just a little bit the protein intake and keep the carbohydrate, but the carbohydrate intake should be from a low index carbohydrate.
So it's a combination of everything and with a final touch of Mediterranean. Okay. You agree? You both are specialists and beneficiary of Mediterranean diet.
It's very luxury products, yes.
Speaking about Mediterranean diet and having here two experts, how would you explain that Greece at least is on one of the top places regarding obesity prevalence? So, because everybody thinks that just following the Mediterranean diet, we are not exactly sure what does it mean except the volleyball and some fish and vegetables. They don't go into details like
it's a very logical question, but the truth is, although we have countries, our diets, especially younger people, have changed quite a lot, become more westernized. And I think this is one of the reasons, the fact that it's not a classical Mediterranean diet, the diet and nothing special with Greece right now in these days. The other things that the statistics, I think, are a little bit inflated because in some of the studies that they have included in the analysis, it's reported way rather than documented way. So there is a bias factor there, but there is no doubt that it's difficult to explain the high obesity prevalence in the country with the classical Mediterranean diet habits. So, but anyway, there's no doubt that the Mediterranean diet is classical form of high vegetable and fruit intake, of fish intake, and olive oil use. Is a healthy diet for sure, but it's not necessarily a diet, that if it's free in calories and in amounts, helps you to lose weight. So if you combine the concept of a diet with a low-calorie diet, I'm sure you can achieve that.
So you're saying that if you drink several bottles of red wine and have a large amount of olive oil liters, salata, and eat a kilo of nuts every night while watching television, no. The amount of the energy that you get in is important.
That's what I said, that it's not only how careful you eat, but how much you eat. So,
I see those the patients come in and say, that you ask them what they are eating. They're always eating or healthy. Fruit is healthy, but if you eat 1 kilogram of tangerine, it's not a healthy eating. It's fruit. Fruit is healthy, but if you eat a lot, it stores as fat. So I think in the beginning, the energy deficit and giving all the macronutrients, you can't just give just one. Protein diet, carbohydrate diet. I would recommend, and I don't think it's generally recommended. So you have to have all three, but maybe for a certain time at certain ratios. So for fat, satiety, no glucose satiety, protein, glucose satiety, so you can exchange, but modestly. In studies for protein, high protein diets, it goes up to 25%. So I think we should be below 20%, 10 to 20%, 15%, and for some time, and we see what's after the weight loss, we can adjust, go back to the athlete traditional style. Of course, fat has the highest number of calories. Alcohol also is close to fat. You can't stop alcohol in some patients. It's having a good, if the patient is having a nut, you will reduce the kind of thing.
Yes, what do you think about Dukan diet? Do you know what Dukan diet is? Yeah. There are a lot of persons, mainly women, that take this and keep this diet, and which is very successful, at least in the first part. So how can we tell them not to follow this diet, and what would be the side effects of the diet?
Hello, my name is Kaczunanka. I'm a specialist in diabetes, nutrition, and metabolic diseases. And I treat some patients from a nutrition point of view, not only diabetes. Dukan is on fashion nowadays in Romania. Many young ladies, which are not very obese, overweight lately, prefer to follow this diet in order to lose 5 or 10 kilos before summer holiday, or now is coming Christmas. But we are trying to explain that this diet is not so healthy. Anyway, half of them can't follow the rules more than 1 or 2 or 3 months because the restrictions are very important for them, and it's very constipation is one of the reasons of abandoned diet. And a lot of them regain the weight loss in first
we show them, most of them have low mass, smooth muscle mass, but the percentage of fat is not very good. And when we see the ladies after they regain the kilos, most of them have many kilos of fat in plus. So we don't think that very restricted diet is a healthy habit. And we explain them that during the weight loss with such a diet, a very amount of weight loss is from muscle. But when you regain that kilos, almost all of them are from fat. So we are against any commercial, restrictive and nonsense diet. And we try to teach our patients to have a healthy lifestyle. Many of them are disappointed. They are waiting from us recommendation that let's say you can eat whatever, whenever, you can stay in front of the TV, but if you drink 2 glasses of water, let's say you will lose weight, and this doesn't happen.
Well, thank you very much for this comment. And I have a question, or I would like you to comment on the dietetic therapy, the nutrition therapy for this patient. What would you give?
From my experience at that PMI, I would recommend to this lady a diet around 40,000 or 60,000 1,400 or 1,600 calories per day, divided in 3 meals and 2 or 3 snacks. The schedule of the meals are very important. Over 80% from our patient doesn't have breakfast. And the main meal is actually dinner. And they are thinking that if they reduce the number of calories, they will lose weight. And many ladies think that if they are consuming less calories but are from chocolate, it's okay, because at the end of the day the calories are not so many. And we are trying to teach them that dividing the calories to macronutrients in the right way, to split their plate into a half, and the half being vegetables and the quarter being cereals and meat, would be a better way to reduce calories and to make mistakes.
Okay, thanks.
Thank you.
Yes, thank you.
We can stay here. Yes.
We can stay here. So I'll go in case. Well, to look at the BMI patient is obese and has several comorbidities. He has hypertension, dyslipidemia, impaired fasting glucose, and sleep apnea. Medical history and additional testings indicated should help to determine whether other obesity-associated conditions such as cardiac disease are present, and we show the algorithm. BMI 32%, so that means, according to the guidelines, is not a candidate for bariatric surgery. But weight loss is indicated, as we all know, and a minimum of 5% of the weight. Do you agree with that ratio? So this is a goal, a reachable goal. So in how many fine. Maybe a year, but 6 months is okay.
I think that for 5% it's enough.
Yeah. It could be 10%, 15 or 20, it depends on the patient, but the goal, the realistic goal is 5% of initial weight. So this is the guidelines. Remind you of what is to be done. Lifestyle modification on all steps, and then comes medications, which will be presented to you afterwards.
I have a comment here and a question, of course.
For the guidelines.
Yes, according to the guidelines. This guideline has been published in 2008, as far as I remember. At that time, we had 2 drugs for obesity. It was Orlistat and Sibutramine. After 2008, we remain only with one drug, which is not used too frequently, the Orlistat. But now we expect some new drugs, and Professor Zigors will tell us. Do you think that with these new drugs, with the new data we have on obesity and its comorbidity, this guideline should be changed?
He was the first. But of course,
It's a question for us.
I think roughly it's correct. I mean, the time point when we have to try surgery. But I mean, you have to look obviously in more detail and see, for example, which drugs are going to be available and what restrictions are going to be enforced about them to actually decide if there is need for any particular change. But I would say that more or less it remains correct. It's just that we don't have a lot of drug options. So I mean, what that means that one can jump easier to surgery in cases of failure of lifestyle interventions. And that is one of the reasons, of course, that surgery, together with the improved techniques and decreasing the complications, have become more popular.
So if any change is going to be made, it would be the surgery going one step up between 30 and 34.9, which is expressed in the recent guidelines as in certain cases because you have to be.
For diabetes, it can be, yes.
So the treatment suggested, again, as we talked, calorie restriction of 500 kilocalories per day. And the amount of weight loss expected would correct many of the pre-existing conditions. Physical activity should be encouraged in this patient. Well, again, with all patients, you have to know the potential limitations, obesity, associated conditions. The options include walking, and the patient can suggest recommend to have a pedometer. We talked before joining the gym, home center program, foundation, aerobic and resistance training. So people have to move. This patient has to do physical activity. In this case, according to the guidelines, this patient, weight loss medication is also an option. Orlistat is the only anti-obesity medication that we have in Europe. Patient should be informed about the side effects of Orlistat, which is, as you see and expect, oily spotting, flatulence with discharge, fecal urgency, because as you know, this drug reduces fat absorption in the intestines, balance the activity of lipase, the taste of lipase, and 30% blood control absorption, so the fat goes into the feces. And fat soluble vitamins, there will maybe absorption, there will be a absorption, but it does not in the long run lead to deficiency, but you should be careful and probably may replace it from the start by giving a multivitamin before bedtime. So process will talk about that, if he agrees with that or not. Well, I mentioned about realistic goals. The patient has to be in the management, not aside, not staying helpless aside of the management team. And strategies for weight management, weight maintenance should be discussed, including continuation of regular physical activity, because maintenance is important, because weight regain is an important issue. It happens. You may prevent it. It happens in also bariatric surgery, after bariatric surgery. So it is the way of life that you have to teach your patient. Quickly, take-home messages. Work is a key. The physician, surgeon, dietitian, physical activity, professional, surgeon, as I mentioned. Listen to your patient, try to improve your patient's health, quality of life, and watch out for regain. And for patients have to be a part of the team. The brain is very important. Listening to the brain. So those people are very more successful than the others. And health is important. Quality of life is important. Rather than getting ready to summer. And watching out for weight regain, leaving the old habits and staying with the new ones. So this is my presentation, and I think Kostas will go on with the medical therapy.
Thank you very much. Thank you both for the kind invitation. All of you that attended this moment for having the courage to be deprived of such a beautiful day. Obviously this is a major concept. That obesity is a disease and we need to treat it as such. Of course, we heard earlier by Professor Heim that this is not always the case, and that sometimes obesity does not behave as a disease in some patients, and especially in the elderly that I talked to you about yesterday. But anyway, this is a general rule that definitely applies to the younger people, and we need to have that in mind in order to be able to treat this disease, obviously an environmental disease that developed over the last few decades, and that, as I said, at least for the majority of people, and the younger ones, it is associated with a rapid increase of mortality risk that starts about 35 and culminates about 30. And this is an example, again, when we talk to younger people that are obese, a more realistic, let's say, representation of what may happen to them. Again, this is on average, it doesn't apply to everybody, as I said, that if you are obese or severely obese, when you are 20, I mean, you are predicted to lose almost 20 years of your life expectancy. So that's a very big impact due to various complications that we had. And just a very interesting slide that shows that what determines premature death in humans, and it can be genetic factors, social circumstances, quality of health care, but a very large part of premature death is due to behavioral factors. And as we see here, obesity and inactivity, that they go together, it's second only to smoking behavior that is responsible for premature deaths, as we said. What is successful therapy? I mean, so far we've been driven mostly by weight loss, by amount of weight loss, and there has been a big pressure by the patients for the amount of weight loss that they will be able to achieve. However, this is not the only target. Maybe it should not be the primary target. I mean, what is important is to reduce the risk factors and the morbidities associated to obesity, not only to lose weight, but to maintain weight in the long term, or prevent weight regain. And finally, which is very important, increase the well-being of the patient that can be achieved with small amounts of weight loss. As I said, I mean, the expectations of the patients and the motivation to lose weight are really unrealistic. You can see here that most of the patients, I mean, more than 50%, they expect to lose 20 to 70% of their body weight, which is a very large amount of body weight. It's not only, does not only apply to the very obese. So there is not an easy prescription for that. Of course, we have to eat less, we have to exercise more, we care about that lifestyle innovation, but unfortunately, we can't alter our genetic codes, so the rest is very difficult to achieve. And of course, there are many genes that can affect our body type, leptin being one of the major ones, and several other molecules along the pathway of leptin action. We have thalamus and the paraventricular nucleus of hypothalamus that you can see in a simple scheme here, just in order to say that actually these are targets for various pharmacological attempts. For example, recombinant leptin administration, MC4 melanocortin receptor agonists, the various serotonin uptake inhibitors or the serotonin receptor agonists, the cannabinoid receptor antagonists, and so on. So most of them seem to act on this very important for appetite control pathway. And of course, I mean, we have the definitive treatment for a very rare case, or for very few rare cases, which is leptin administration in cases where we have leptin deficiency, gene to mutations. And as you can see, there is hyperphagia and severe obesity developing from very young age. And when leptin started being given, then you can see that this dramatic change and this body type change over a few years. And unfortunately, as you all know, obesity, common obesity, is associated with leptin resistance and not with leptin deficiency, and therefore we can't overcome this block the same way as we can't easily overcome the block of insulin resistance, and therefore leptin drug is not an effective drug. So, with the exception of these very rare monogenetic causes of obesity, that we may have a solution. However, for any other type of obesity, we need to start with dietary intervention, with physical activity increase, and this is a necessary requirement for every pharmacological intervention. So we should never prescribe a drug, an anti-obesity drug, without prescribing a lifestyle intervention at the same time, and this is actually what is demanded by the indications of the drugs. And of course, I mean, this is one of the reasons that, as I said, although we may have 50 or at least 20% of the population that are really obese, however, a very small proportion of them are characterized necessarily as obese, and even much smaller percentage is treated with drugs at some point, which is probably less than 5%. One of the reasons, of course, is that we have been left, as Professor Roman said, with only one drug that is approved, at least in Europe, and we see about the USA. Sibutramine and ribonucleic have been taken out of the market, but for all drugs, and these ones, and the ones that are approved in the US, the indications are more or less the same. That is a BMI of greater than 30 or greater than 27 if they are comorbidities associated with it. But if we come to insurance purposes, I mean, the criteria will be much higher than that. Of course, as I said, a requirement is to use it with a lifestyle prescription. And of course, to get to this point with only one drug available in the market, I mean, this slide actually shows the rising fall of drugs, anti-obesity drugs so far. I mean, thyroxine was used and disproved because of thyrotoxicosis. Amphetamines started back in 1937, but they were removed from the market because of tolerance and psychosis. We have the famous combination of fentanyl and fenfluramine that was removed from the market because of pulmonary hypertension and cardiovascular disease. But fentanyl still remains. The combination with fenfluramine was removed from the market. Sibutramine, which was a very good anti-anorexigenic drug in a way, it was only allowed to circulate 3 years because of this study that was done in patients that were contraindicated to have actually the drug with established cardiovascular disease. It showed that it had some increased heart risk. And finally, rimonabant, which was withdrawn because of increased depression symptoms and some suicidality attempts. We are left with Xelipral. As you already heard, it's a pancreatic lipase inhibitor that prevents by 30% the absorption of triglycerides by the gut. This is the famous Sender study over 4 years that shows, as with all drugs, that we have very dramatic decrease in body weight, significant over placebo by 1 year, and then it starts climbing up, but remains side effects, and Professor Jimmy already said that you may need some time, some experimentation. But if you adhere to a low-fat diet, really you don't usually get the gastrointestinal side effects, so you can use the drug. But it's a very expensive drug, and as you see, the gain of a placebo, which is lifetime placebo, is only, let's say, 3 kilograms over 4 years. So it's a very expensive therapy for that length of time. Nevertheless, and it has been shown that it has significant metabolic benefits in addition to weight loss. And you can see here that if you analyze those patients that have impaired glucose tolerance, and you can see that Zenican over these 4 years prevented by 45% the progression to type 2 diabetes. So that's a very important gain that you may have. It is not apparent in the amount of kilograms that you have lost. And in this large meta-analysis and forest plot comparison of Forest versus placebo, we can see that we also have additional metabolic benefits. We have a significant above placebo reduction in blood pressure, and both in the systolic and diastolic blood pressure. And the same applies to the lipid profile. I won't extend to that because we've heard it quite extensively. Now, just to say one word about Anlai, that is half dose of Zeneca of Orlistat, 60 milligrams, that can achieve 80% of the efficacy with 40% less side effects. So that is an over-the-counter preparation that is out in the market in some European countries and worldwide. That is Orlistat, 60 milligrams a month. And just one word about sibutramine, because it's a category of drugs that, although sibutramine has disappeared, there are some other drugs that can be used from the same category, and we will see later. Now, it is an norepinephrine and a serotonin uptake inhibitor, which increases energy expenditure as well as reduces appetite. Now, one slide for the endocannabinoid receptor antagonists. Now, they, rimonabant and a couple of others that were withdrawn from clinical trials because of insufficient either clinical effect or safety concerns, have central effects whereby they reduce the reward of food, the pleasure of food in a way, and they suppress appetite, but they have also peripheral effects where they improve, they reduce lipogenesis, and so they have a dual action. And now the effort, I'm not going to talk about that at all, is to actually develop peripheral cannabinoid receptor antagonists that will have the peripheral benefits without the central effects that are responsible for the side effects. And now I come to the this new combination therapy, which is based on already existing drugs and licensed drugs, and that has been approved in the States by the FDA, but unfortunately it has been rejected by the EMA. This new combination that is called Qsenia in these days Now, is based, as I said, on the combination of fentanyl, which exists in the market for several decades, and topiramate, which is a convulsant drug, and it has been used for also migraine prophylaxis. And you can see that the anticonvulsant dose of topiramate is about 400 milligrams, and the migraine prophylaxis dose is 100 milligrams, while the fentanyl license for short-term use, which is only 12 weeks, that existed from the 50s, is up to 30 milligrams. So what they did, because each one of them, if it's given to high doses in order to be able to achieve the weight-reducing effect, causes a lot of side effects, they combine them both with a much smaller dose. Topiramate, a middle dose of 46 milligrams and a high dose of 92 milligrams, which is less than the 100 for migraine prevention, and fentanyl of 7.5 and 15 milligrams. So this achieves a much better side effect profile with an additive weight loss that can be quite significant, as we see here. Probably it's the most significant over placebo weight loss that we have seen so far with any of the medications that have been in the market, withdrawn or not. And you can see here that with the high dose, 15 fentanyl and 92 topiramate, and at 1 year, we have approximately 10% above placebo weight loss. So that's a significant weight loss, and this again shows the amount of weight loss at 1 year, at 2 years. So this is at 2 years, and this weight loss continues almost unaffected at 2 years, which is very important. So it's not only a more acute effect as we thought it was, but it seems to be persisting at least over 2 years, so it is promising. And you can see that about 50% of the patients can achieve 10% weight loss at least, which is a very significant effect, and the majority of them, 70% of the patients, can achieve 5% weight loss. So it's quite significant effect on body weight reduction, with the combination of low doses of 2 drugs that individually, in order to achieve this body weight loss, we would have to be given much higher doses and therefore have much more side effects. And obviously there is concern about increasing pulse rate and blood pressure, because fentanyl is a sympathomimetic drug. However, and if you can see in this analysis, at 1 year, you can see both significant reductions in systolic and diastolic blood pressure compared to placebo, as well as reductions in the number of antihypertensive medications compared to placebo. So, the eventual effect that is achieved after the weight loss, that is obviously weight loss associated, is an improvement. And if we take another analysis that shows the annualized incidence rate of population with diabetes, type 2 diabetes, you can see that although in this population on placebo it was almost 4%, the annual progression to diabetes, however with the higher combination dose, it drops to 0.9 incidence rate. So it's a very significant effect, preventive effect. And this slide you saw yesterday by Professor Misic also, it shows that both at the mid dose and the high dose, quality of life and physical function and well-being. So, I mean, one would wonder then why did the EMA refuse approval of the drug, especially if the FDA had already approved it. However, I mean, the main concern is that, first of all, the danger of abuse by a large population of these patients, tolerant patients. And secondly, because they still they are not persuaded about the safety, the cardiovascular safety in the long term. And of course that you cannot prove because you have to do long-term studies or to wait for long-term results before you are sure. And third is the fact that at least topiramate can cause cleft palate and cleft defects if it's taken during pregnancy. And so the indication requirement is that you have to have a pregnancy test before you take the drug. You have to, at least in the US, you have to check a pregnancy test every month on treatment. And ideally, or you should take actually a contraceptive drug. So, I mean, but this was the main concern of the EMA, if you see the decision, that they decided that they are afraid of the abuse and they are not convinced of the cardiovascular safety. This is one drug that is on the other side of the line that we don't have, and the other one is lorcaserin. Now, this is a selective serotonin receptor 2C agonist. Now, the serotonin-energic drugs like fluramine, and were obviously withdrawn because of these heart-bound problems that they cause, the serotonin-energic syndrome, as we say. But this is caused by the serotonin 2B receptor, and lorcaserin is selective 2C receptor that is only expressed in the hypothalamus. As you can see, however, that the weight loss efficacy is much smaller than the Leucemia efficacy. But nevertheless, as we said, we should not only aim to weight loss, but also the combination of side effects and metabolic benefits. And you can see that, here you can see smaller of a placebo weight loss, but it's quite significant. And in this study of all the patients that participated up to approval, actually there was no significant increase in the number of patients that met the cardiographic FDA criteria of cardiopulmonopathy that were taking the drug, which means that there is no increased risk of cardiac valve disease. But again, at the EMA rationale for rejecting this drug approval also, they say that you never know what's going to happen in the long term, because we have only 1 and 2 year studies. But nevertheless, the advantage, I would say that the advantage of the lorcaserin compared to the leucemia is that probably it has a more, it doesn't have a cardiovascular risk profile based on this, and it's probably a safer drug. It doesn't have any major other side effects, and therefore it may be easier to use. And finally, I will finish with a few words from the other drugs that are expecting approval, at least by the FDA, for use in obesity. And the one is the combination of bupropion and naltrexone. Again, this tendency of combining two pre-existing licensed drugs for other indications with smaller dose achieve an additive weight-reducing effect. Now, bupropion is an appetite suppressor that is an antidepressant and not a opioid receptor antagonist, sorry. And then this is another combination that is pending approval. And here we have liraglutide and exenatide that are licensed for type 2 diabetes that have also a significant weight reducing effect in non-diabetic obese patients. And I'll just show one slide from the naltrexone and bupropion studies. Again, quite significant weight loss outlined here. And this is a study with exenatide in non-obese patients. Again, quite significant weight loss over placebo. And the same with liraglutide. It's interesting to see with these two GLP agonists that we have a very high number of nausea and side effects like that. But however, they are much high and very intense at the beginning, but they tend to subside after a few weeks. So if you're able to go through them, then the side effects of nausea get better. So, to conclude, based on all that, prescribing for obesity, like for hypertension, this is dependency, is actually a chronic disease management paradigm. So, if you decide to prescribe something for obesity, you have to prescribe with a long-term intention, and you have to use probably a combination of drugs that can achieve higher weight loss with less side effects. Of course, the essential requirements should always follow an anti-obesity drug prescription, and from what we discussed, I mean, safety and tolerability remain very important key factors in the decisions of licensing new drugs. And you can see that the EMA is more strict than the FDA in that. I think this relies on the fact that the FDA has really realized that even if you have a small weight loss, you can have significant metabolic benefits, while in the EMA they are a little bit more strict about that. And finally, the combination therapies using local drugs are preferable, and this is probably shown in this projection for over the next decade of the use of combination drugs. There is more than 50% of the cases, and the rest is divided amongst malabsorption drugs and cardiovascular drugs, suppression drugs, and synthetic drugs. So, thank you for your attention.
Thank you very much for this update on the medications that we don't have yet. But it's important to know. And hopefully we'll have also these two new classes. But what is interesting that looking on internet or going to pharmacies, you can get so many products or medication for weight loss. Why do you say that we don't have?
Well, actually, I mean, since you mentioned that, a patient of mine that I'm happy to discuss with the possibility of Lucidia, and that unfortunately was not approved for Europe, but she found it on the internet, and she ordered it through and apparently what she received eventually was a fentanyl-only preparation. So it was a fake in a way. And when I asked buyers, people who use the drug, whether actually the drug is available in the market in the they said no, and obviously they don't allow that. And obviously, and this can probably apply with all the other drugs, because as we have today, there is distribution in manufacturing in India, China, Brazil. So sometimes we may get some of that from the internet, some of them may be good, I don't know. But I mean, some of them may be fakes.
Yeah. Any questions or comments? Yeah.
First of all, I would like to thank all speakers for their excellent lectures. And my question concerns the outcome of various diets. So it's for Professor Jung, of various diets. And do we know how this kind of diets impact on body composition? Because in the end, what we want to have is to avoid sarcopenia and to have a body composition that is also compatible with a metabolically healthy person. And maybe in connection with my first question, we know how to adjust the physical therapy to these types of diets.
Well, what I'm going to tell you is that the final diet program, which is the healthy eating, reducing the fat, increasing the protein, and in the carbohydrate, you can stay the same ratio, but could have for a short period of time less amount of carbohydrate or reduction, small, modest reduction. And then, importantly, go with the glycemic index of carbohydrates. If you devise such a diet program, when you do the follow-up with the body composition analysis, you will see that you won't be losing much of the muscle, the free fat mass, and you would be losing the fat from the abdominal area in combination with the physical activity. Again, that you would be losing physical activity. It doesn't have to be a resistance program, but it could be aerobic or increasing the leisure activity. So you would have beneficial results. If you're asking for studies that I could cite for these, I just have the 3 studies for the diet. For the physical activity, I think I can't cite you any one right now, but I would send you some showing if there are any long-term, large, randomized studies. Your questions was excellent, and this is what we had to give to our patients, and it's not anything beyond what I have told you. So we should stick to the guidelines and healthy eating, modestly play with the ratios according to the patient, and so eventually we would reach our goal. Second question. Was there a second question?
You just answered it. Okay, so basically we have some major guidelines and not so many diets.
Well, for dieting, if you go in the associations related with diet, there are guidelines, physical activity guidelines, as we have bariatric metabolic surgery guidelines, obesity management guidelines. Anything you'd like to add?
Well, as far as I've read, one of the reasons to recommend moderate increase in proteins is exactly this one, not to lose too much muscle mass. But of course, it strongly depends on the rapidity of weight loss, because if we induce a very rapid weight loss, that means that we lose a lot from muscles. And without physical activity, it's a greater decrease in muscle mass. So also this is very important, not only the component of the diet.
I have a question for Professor Tsigos. I observed on the presentation that the placebo group had a weight reduction of 3 or 5 kilos. And if they got some injection, like in liraglutide, the injection was more effective. Even with no
Aerobic exercise, I don't recommend many times for obese and diabetic patients which have cardiovascular disorders, only in rehabilitation centers. And because exercise, as I said, is underestimated by patients, it's recommended to make the patient make a program along his activity days of living. So we can use our meditation and use his activities, professional activities, daily activities, and make exercises.
Thank you very much. That's a very helpful information. As you know, what I said yesterday also about the diabetic patients, there are limitations for the diabetic patients and also for the cardiovascular disease patients. For patients obese and having osteoarthritis, osteoarthritis in the knees, you can't urge, you can't force them to walk with all that weight on, so you would recommend swimming, for example, if they have access to it. So it depends on individual cases according to the limiting condition.
Yes, but is there an exercise, isometric type exercise, which can do any kind of patient, because not with cardio effort. So, and you can make the isometric exercise at home, when you watch TV, or at your desk, or at work. This is the kind of exercise I recommend for us too, because every move which makes prevention in our muscle is benefit, and it means health for bones too. So
You're right. I mean, you can increase the amount of non-exercise physical activity in such cases. Anything is
for maintaining the muscle tonus, yes, and which is important in diabetic patients when they have neuropathy, which means hypotonia. When about diabetic patients, we can talk until the morning, so there are a lot of things to do, especially when we have diabetes food, where are very much disorders in muscle, in tendon, in bone structure. So, yeah, we have a lot of things that people very want.
So it's you who's going to do that here.
Comments or questions?
I'm a family practitioner working and living with young groups. We have 2,300 patients there, aged from 0 to 95 as far as I know. And my question is for you, Professor Roman, is what are some maybe
as a general practitioner, of course, it's very important to try to prevent any disease related, first of all, weight increase, and secondly, any disease related to obesity. If it's possible also to discuss with people who are at risk for increasing weight or already with weight problems at risk to develop other comorbidities. And the general principles of lifestyle management are not so difficult to be done, so I'm sure that you will be able, you and your colleagues and everybody from the general practitioner to be able to induce the first steps in lifestyle optimization. So to advise people to have some more steps to done, or more physical activity, or to reduce, let's say as a first step, the foods very rich in fats. So these might be small steps, small advices, specific advices to induce modification, change in lifestyle. And of course to monitor the results, and if it's not possible or the results are negative, then to refer to a specialist. Maybe they have something else and they cannot follow your advice.
Are there any programs designed for family practitioners?
Would you like to have?
Yes, of course.
Okay.
And
So,
also my colleagues, many of us.
well, in this case, yes, in this case, I'm very sorry that your colleagues are not here.
They were yesterday.
Yes. Okay. And if you'd like, so we can be in contact. We can discuss next weeks, and we can organize some courses. Unfortunately, without our guests, because it's not possible to come every week here, although they want to do this, I'm sure. But we really can discuss and to organize something like this. And thank you for this suggestion. So, if there is no any other question or suggestion to be made, I would like to thank Professor Young for organizing this course as chair of the Obesity Management Task Force of the European Association for the Study of Obesity. And also to thank Professor Zigos for his presence and for his update on these wonderful drugs addressed to obesity management, and also to thank you for the presence here. If you agree, I would suggest to have these slides, and maybe for those who want to, yeah, it's okay. So, if someone would like to have the slides, please tell us, tell the organizing agency, and you will be able to get the slides. So, thank you very much again, and the last message from the chair of this course.